So welcome to today's session. I'll give everyone a minute or so to get into the room and get audio set up. My name is Kirsten Forsyth. I'm an associate director on NASTAD's drug user health team. Welcome to the first webinar in a series of 5 addressing the intersections of syphilis and drug user health. This one is called If You're Not Seeing It Yet, You Will, Collaborating to Address Syphilis Among People Who Use Drugs. A few housekeeping items before we get started. Everyone will be on mute to ensure a good recording, but please feel free to add questions in the chat at any time. We do have folks paying attention to the chat so that we can make note of all your questions. There will be some space for Q&A during the webinar, but we will also plan to follow up on any questions that don't get answered afterwards. Webinar follow-up will also include a video of the recording, and the slides will be made available as well. We had a full registration for this webinar, which is super exciting to see. Over 1,200 people registered, which hopefully demonstrates the interest in this topic and the importance of being able to have these collaborative conversations. On that note, our capacity for this meeting is 1,000. So if you have colleagues who are trying to get in and having trouble getting in, just let them know to wait a few minutes and try again. I think we're only at 600 folks right now, so plenty of room for more to join. So before we dive a little deeper into this topic, I just want to note that this webinar series is a collaborative approach. I think, as you know, we're talking about collaborating and across different sectors. We're talking about partnership and addressing a syndemic and multiple interrelated issues. So hopefully we're leading by example a bit here. NASTAD has collaborated with partners NACCHO, the National Association of County and City Health Officials, AIDS United, the Northwest Portland Area Indian Health Board, and the National Coalition of STD Directors. And this issue first came up for me in a technical assistance request that we received from a harm reduction program in Baltimore City, who was looking to find ways to contribute to the city's approach to reducing syphilis and congenital syphilis. So I reached out to a few brilliant colleagues, many of whom are here today, who know a lot more about syphilis than I do, and we're already working on this intersection. So really excited that that has culminated in this webinar series, and today the first webinar in the series. So just to get us started, we wanted to do a little temperature check and find out who's here with us in the room. So I'm going to launch a poll. It's my first time doing polls on Zoom, so hopefully this works well. But in a moment, you'll see a poll come up on your screen. And we'd like to know, how would you describe the primary focus of your role? And please just select a single choice. Do you work in harm reduction or work primarily with people who use drugs? Do you work in STI prevention or treatment? Are you sort of a unicorn person who would describe yourself as doing work in both of those areas, or neither or other? I'll give everyone a few more seconds to answer. It looks like we've got primarily, so majority are STI prevention and treatment staff. Wonderful. Got just about 10% harm reduction and working with people who use drugs so far. A quarter of folks describe themselves as working in both of the above. And then for those of you who selected neither or other, I'm curious, could you maybe enter in, type into the chat, what kind of work do you do? Okay, we've got State Department of Health folks, HIV case management, a few of those, behavioral health policy, DIS, epidemiology. Awesome. Philanthropy. Oh, very cool. Oh, Renee. Yes, glad you're here. Great. So thanks everyone for participating. It's really amazing to see so many different sections of public health and social services and human services represented here. So we've got one more poll to kick us off. I am curious, how would you describe your current knowledge of the intersection of syphilis and drug user health? 1 being low, little to no knowledge, or 5 being extremely knowledgeable? We'll give folks another 15 seconds or so to answer. Okay, I'm going to end the poll in a couple of seconds and share the results. Thanks, everyone. It looks like we've got the majority of folks at a 2 or a 3, quite a few just right in the middle of the range there. And then 28% at a 4, which is awesome. And feel free again to put any information in the chat about where you're coming from and what your background is on this topic. Because we have so many folks in the webinar, it might be a little less interactive in terms of sharing knowledge with each other, but it's really great to see that we have a range of folks that have a bit of prior knowledge on this topic. And there may be some things that are not new to you here, but hopefully there's some new information or new possibilities of partnerships or integrated work that comes out of today. So moving forward, here's our agenda for the rest of the session. Welcome. That's the part we just did. And then I'm going to hand it over to my lovely colleagues, Kate Brookmeyer from the CDC and Kat Kelly from NACCHO, to do a bit of an overview of kind of big picture. What does the epidemiology look like of syphilis? How does it relate to substance use? Why should we care about this intersection? Who are some of the kind of health systems and partners that might be involved in a coordinated response? Then we'll move into breakout sessions. You will be given the option to choose which breakout session you'd like to go to. We have one that's for STI staff that want to learn more about harm reduction, and one that's for drug user health or harm reduction staff that want to learn more about syphilis. And then we'll come back together for a brief closing and a preview of the upcoming webinars in the series. So with that, welcome. Thank you everyone for being here, and I will pass it over to Kate.
Great, thank you so much. I'm just going to pull up my notes here. Good afternoon, everybody. I'm Kate Brookmeyer. I'm the Senior Advisor for Harm Reduction in the Office of Director and NCHHSTP at CDC. And I'm so thrilled to be able to talk to you today. And as Kirsten mentioned, as you have questions, please don't hesitate to put them in the chat. Hopefully we'll get to all of them afterwards. Next slide, please. Great. So today we're really going to be understanding and exploring the links between syphilis and injection drug use. And I've divided this talk into 4 parts. First, I want to talk about the marked syphilis increases over time, the high rates of drug overdose, the syndemic or the correlating high factors between syphilis and overdose, and then what we can do or the next steps in prevention. Next slide, please. Next slide, please. So first I want to jump into this in terms of syphilis. And I want to tell you about the surging primary and secondary syphilis rates. And I want to show you this chart because this is 2011 through 2020. And it is especially notable is the increases in primary and secondary syphilis in the US among women and men. You see during the last year, 2019 to 2020, the primary and secondary syphilis rate among women increased 20% and the rate among men increased 4%. But then if we look at everything over 10 years, primary and secondary syphilis rate among women increased 422% and the rate among men increased 156%. So you can see things are trending in the wrong direction. Now I want to look at this another way and show you another way that we often look at these. We often look at this in STD. We look at the distribution of cases by sex and sex of sex partners. So meaning what sex was your sex partner? And as you can see here, this has some really important information for our prevention and intervention efforts. About 40% of syphilis cases were among men who have sex with men only. And all men and their sex partners accounts for about 80% of total syphilis cases. So you can see men in large part are driving this, but we see that women are at 19%, and that's really important for its implications around syphilis and congenital syphilis in particular. Next slide, please. So here you can see the increase in primary and secondary syphilis among women especially well, especially in the jump in cases between 2019 and 2020. So if you see women in the kind of dark black or navy, you can see how it's jumped up over the past year. During 2019 to 2020, the number of cases among MSM decreased 2%, but the number of cases increased 21% among women. This is from 2019 to 2020. And during this whole timeline, 2016 to 2020, the number of cases among MSM increased 11%, while the number of cases among women increased 159%. So you can see that although men are the majority here still, women are showing a very concerning trend upward. So I want you to keep that in mind. Next slide, please. We also know that HIV co-occurs with syphilis infection. So I was glad to see some of you were in HIV care and treatment. Among primary and secondary syphilis cases with reported HIV status, about 50% of cases among men who have sex with men were HIV positive, and 5% were cases among women. So you can see these two epidemics, or rather syndemic, is very much co-occurring, and you see that especially well within the MSM category. Next slide, please. Great. Now I want to talk, so that was a little bit of a primer on syphilis. For those of you guys in harm reduction, for those of you in syphilis, I'm sure that was a review, and that's great. But now I want to talk a little bit about overdose deaths and people who inject drugs for you. So as you all know, rise in opioid overdose deaths in America really happened in 3 distinct waves. In the 90s, there was a marked rise in the prescription opioid overdose deaths, and that's prescription opioids prescribed by doctors. Then in 2020, we saw a marked rise in heroin overdose deaths, which is an illegal opioid. And then in 2013, up to now and increasing, marks a rise in synthetic opioid overdose deaths, and that's including illicit drugs like fentanyl and xylazine. So this is not sort of a one and done story. And I should also mention that drug overdose deaths involving psychostimulants like meth are increasing with and without synthetic opioid involvement. So we have a lot of things happening here. It's a very complicated epidemic. And next slide, please. Okay, this is another way to look at things over time. There's been a surge in synthetic opioids, which are extremely deadly. That's the purple line right here. And drug overdose deaths, as you know, have risen 5-fold across the past 2 decades. Next slide, please. But we do the work that we do because prevention is possible. And this is a chart of potential opportunities for intervention in 2021. We see that the fatal drug use was often witnessed. There were mental health co-diagnoses. A potential bystander was present. That's in 46% of the cases, which I'm going to come back to. There was a prior overdose, so meaning a warning there. And sometimes there was a recent release from an institutional setting, like an incarcerated situation. So 66.8 overall percent of drug overdose deaths had at least one potential opportunity for intervention. And that's where CDC really comes in particular. Next slide, please. Now I want to talk about the syndemic and bring together these 2 strands of work from opioid use in people who inject drugs and STDs, and syphilis in particular. Next slide, please. So what is a syndemic? I feel like this is a very popular term right now, but it's good to just take a level set and make sure everybody's on the same page. So the syndemic is a population level clustering of social and health problems. So 2 or more diseases or health conditions that cluster within a population. And in this case, I'm talking about syphilis and overdose. The contextual and social factors that create the conditions for clustering, meaning the same predictors played a role in both in risk factors. And the results in adverse disease interaction, like biological, social, or behavioral, increases the health burden of the affected population. So meaning these things are functioning together to make things even worse. Next slide, please. So here I want to show you, this is a figure of reported injection drug use among primary and secondary syphilis cases by sex and sex of sex partners in the US through 2018. I want you to notice here that the trend has reversed a little bit when we're talking about injection drug use among syphilis among injection drug use specifically. So you see women are now making up the majority, and MSM is at the 3rd tier. So during 2014 to 2018, the proportion of primary and secondary syphilis cases that reported injection drug use within the past 12 months literally doubled among women, and men who have sex with women decreased slightly among men who have sex with men cases. During this period, the proportion of women who have primary and secondary syphilis cases reporting injection drug use decreased slightly, and the portion of men who have sex with women syphilis cases reporting in drug use increased to 7%. In contrast, MSM, primary and secondary syphilis cases reporting injection drug use decreased slightly from 3.6 to 3.1%, so small decrease. But I want overall for you to see these trends among women and among men who have sex with women in particular. That's very important to this syndemic. Next slide, please. And I want to cast a little bit of knowledge in terms of why these 2 things might be so incredibly co-occurring and indeed forming the syndemic. So this is a figure from Copen and colleagues of prevalence of selected reported sexual risk behavior in the past 12 months among women men who have sex with women, and men who have sex with men with primary and secondary syphilis who reported injection drug use. So again, this is among syphilis cases who reported injection drug use. And it's broken out into women in blue, men who have sex with women in navy, and men who have sex with men in purple. And I really want to spend a second on this slide because I want to show you some of these network connections that are happening between sex partners. So look at the proportion who had sex while intoxicated or high, sex with another PWID or person who injects drugs, and exchanged drugs or money for sex. Women are leading this, but you see it's high across the board, very, very high. And this might be a clue into how some of these things are related. Next slide, please.
Kate, there's a quick question that I just want
Sure.
to highlight because it's about this slide. The question is, are the cases for individuals diagnosed with early latent syphilis not considered in these slides?
Exactly right. They're not considered in these slides. We're just dealing with primary and secondary. Thank you for the question. Okay, so in terms of understanding these links, what we saw on the previous slide is that more than 50% of people who inject drugs reported sex with another person who injects drugs, which strengthens existing evidence that IDU and sexual risk behavior can co-occur to facilitate HIV and STI transmission. I hope that link makes sense to you all. And then we've also got between 20 and 40% of PWID reporting exchange sex, which indicates the potential lack of basic health needs, such as adequate food, education, employment, and housing. Something that didn't appear on that slide, but that I want you all to be aware of, is that among syphilis cases reporting IDU, a significantly higher percentage of women with incarceration history, so been in jail or prison, reported engaging in sexual risk behaviors than those without incarceration history. So meaning if you had previously been in a jail or a prison and you were a woman with syphilis and injecting drugs, you had sometimes up to 6 times more likelihood to be expressing these sexual risk behaviors, which then makes you more at risk for HIV and STI, et cetera. Next slide, please. Oh, sorry, PWID. I just saw that question in the chat. It's people who inject drugs. So these are our drug using folks. And the reason I highlighted incarceration history in particular and wanted to draw attention to that is because this is playing a very significant role, which is another arm potentially of this endemic that we're talking about. And when we talk about incarceration history, we're also talking about the criminalization of substance use and sex work as an additional driver of this endemic. We know that criminalization exacerbates social determinants of health, and that a criminal record is a direct barrier to housing and employment, and interactions with law enforcement and criminal justice system can be traumatizing or disruptive. People may be hesitant to seek health or harm reduction services due to fear of criminalization or associated stigma. And this is a huge barrier to prenatal health care for people and women in particular who use drugs. And I just want to bring that home in terms of congenital syphilis. Poor access to health and harm reduction services for justice-involved people also means high rates of overdose deaths after release. So there's a number of ways that syphilis and injecting drug use is related. And we've also got the role of HIV, and we've also got the role of incarceration history. Next slide, please. Okay, I'd love to bring this all together in terms of the next steps in prevention, because I've painted kind of a bleak picture, but we do have next steps that we can take. And there are things that we can do as a community. Totally more harm reduction programs. So key actions to address endemics. First of all, we put the people first. Absolutely put the people first, not their disease, not anything else, but the people, because this is essentially a syndemic of people. We focus on equity. CDC in particular tries to put our money, and we're working on this even now, still put our money where our epidemic is. So if the money is in with people who inject drugs, put the money in syringe exchange programs, for example. We try to leverage policy as a public health tool and really make a difference. And we support workforce and partnerships. And an example of that is really this talk today. Next slide, please. In terms of next concrete steps between people who inject drugs and people who have syphilis, I want to say that overall, we could really be strengthening partnerships between STI prevention programs and other areas of the US healthcare system, in particular SSPs. And the goal of my program in the infectious disease consequences of opioid space is that we are trying to, really strengthen these partnerships and make syringe exchange programs part of the larger public health infrastructure. That is one of our main objectives and goals. We also don't want to disregard the structural, financial, personal, cultural barriers that may affect timely clinical care for syphilis. So as I talked about, criminalization is one, stigma is another, access to healthcare fundamentally is yet another. There are so many things happening here, and we can't ignore these fundamental features that affect timely care. And PWID, or people who inject drugs, may be concentrated in specific geographic areas and may benefit from screening guidelines that are tailored to local syphilis epidemiology. And I should say the same thing could be said for opioid deaths and overdose deaths. If we know that these things are happening in specific geographic areas, we can bring programs together and work with them together and collaborate to see what these underlying risk factors are and to try to really ameliorate this endemic as it's happening. Next slide. And that is it for me. If you have any questions, please put them in the chat, or please feel free to email me directly. It's been an absolute pleasure. And I'm going to turn it over to my friend Kat.
Hey everyone, I'm Kat Kelly. I'm a senior program analyst at NACCHO, the National Association of County and City Health Officials. I lead a chunk of our harm reduction work and a number of projects that are at the intersections of harm reduction, STIs, and hepatitis, and I use she, her pronouns. So I just want to start out by thanking Kate for that wonderful presentation. In this next part, we're just going to dive a bit deeper into the syndemic and factors that contribute to it, and then discuss some key systems, stakeholders, and strategies to help address it. Next slide, please. So while this webinar series is focused on syphilis and drug user health, I want to take a step back and situate it within this larger syndemic that also includes other STIs, such as chlamydia, gonorrhea, as well as HIV, and viral hepatitis. And of course, we highlight overdose here, but other substance use related harms. And all of these trends, HIV, STIs, hepatitis, disproportionately and inequitably impact people who use drugs. So I have a few stats on the screen. I won't go into too much depth because I know Kate covered some of this. But we've been seeing outbreaks of HIV among people who use drugs in at least 10 jurisdictions across the US since 2015. We've also seen STI rates have been at record levels, breaking those levels year after year, as well as viral hepatitis cases have increased. We've seen a dramatic increase in hepatitis C over the past decade. We've also seen progress against hepatitis B stall, and between 2016 and throughout the beginning of the pandemic, more than 35 states reported outbreaks of hepatitis A, which also disproportionately affected people who use drugs. So this is honestly not even the full thing, right? There's a number of other conditions and diseases that are closely related that also inequitably impact people who use drugs. But I did want to start out by just situating us within this context. Next slide, please. So I'm gonna, I won't talk too much about, the nature of a syndemic because Kate defined it well. But essentially the term syndemic refers to a synergistic epidemic. It's at least two different epidemics, so two diseases or conditions, health conditions, that cluster within a specific population due to social or contextual factors, and they don't just coincide, they ultimately make each other worse. Next slide, please. So basically, the sort of like plain language version is two or more diseases and health conditions among the same population, and they make each other worse. Next slide. So I'm sure there are some people on this call who absolutely love these kind of models and frameworks. I'm sure there are others for whom this, won't particularly resonate. But I've included on the screen two leading syndemic models, and I want to call your attention specifically to the role of social and contextual factors. So the model on the left talks about, quote, social and economic disparities, while the one on the right talks about, quote, disparity conditions that promote disease clustering. And while we often focus on the diseases or health conditions themselves and how to respond to them, it's important to remember the role that these social and contextual factors play, and they really contribute to the clustering of these diseases and also the inequities that we see in terms of who is impacted by these diseases. Slide, please. So on the screen, I've adapted sort of the classic social ecological model to highlight some of the factors that contribute to the syndemic of STIs and substance use. And so while we're focusing on people who use drugs for this webinar series, it's also important to recognize that this syndemic of STIs and substance use, or I should say substance use related harms, also occurs in other overlapping but distinct populations. So Black, Indigenous, and other people of color are also disproportionately impacted by STIs and overdose, as are LGBTQ people, young people, people who have been involved with the criminal justice system, and people experiencing unstable housing. And when we talk about who is inequitably impacted, we're not just talking about rates. So, who is getting HIV or STIs, for example. We're also talking about adverse outcomes. And so that's why I've also made sure to include pregnant people here. They may not be at, greater risk for STIs, but they are at greater risk for negative outcomes, such as congenital syphilis, which we'll talk a bit more about in a few slides. So as this slide demonstrates, a broad range of factors contributes to the syndemic of STIs and substance use related harms. At the individual level, there may be some direct intersections. So for example, certain substances can increase someone's libido or reduce their inhibitions. I think Kate, did a really great job of talking about some of the interpersonal or community factors, such as the relationship between syphilis and a history of exchanging drugs or money for sex, as well as sort of the network piece. I also wanted to note, sex and drug use may occur in the same social setting. So for example, I don't know about you all, but I'm personally much more likely to engage in sex or drug related behaviors at a party than I am at a library, right? And we also see this network connection. So if people who use drugs are at higher risk for STIs, that means also that their peers and their social networks are at higher risk for STIs. So you can have the same amount of partners, but you're more likely to get syphilis. Then we also see that there are shared barriers to accessing health services. So some of the ones I've highlighted on the screen are low rates of health insurance, as well as affordability, accessibility, and availability. So for example, can you afford to get tested for syphilis? Can you find a clinic that stocks bicillin, the treatment for syphilis? Can you find a clinic that's non-judgmental for people who use drugs? Competing priorities, this is certainly something that we can all relate to. But for example, if you're struggling with some of these social determinants of health, such as unemployment or unstable housing, you might have less time to dedicate to treating some of your health needs. And then I also want to draw attention to the role that stigma, criminalization, discrimination, and medical mistrust also play as barriers to services. And these certainly impact people who use drugs because of that identity. but they also intersect with some of these other populations and identities that are highlighted in the bottom left of the screen. So for example, experiences of racism when seeking health care may deter someone from getting tested for syphilis, or fear of criminalization of drug use or sex work may deter someone from getting access to services. As well as, we know there are, reports of homophobia and transphobia when LGBTQ people seek health services. So there are a lot of different ways that stigma, fear of criminalization, medical mistrust really deter people from seeking health services. And then finally, the social determinants of health are also a really key part of this. So unemployment, poverty, lack of transportation, housing challenges, involvement with the criminal justice system, and once again, stigma and discrimination. All of these factors really cluster to contribute to this syndemic and this clustering of these related health issues among some of the same populations. Next slide. So what happens when people can't get health services? So immediately on an individual level, we see what, for the purposes of this slide, I refer to as unprotected substance use. Basically a term I made up to just fit some small text on the slide. But essentially the opposite of safer drug use. So if people can't get access to harm reduction services, that means they might be reusing equipment or sharing equipment such as syringes. It might mean that they're using alone or without naloxone on hand. Or they might not have access to education about safer use practices. And that results both on an individual as well as on a broader population level, increased overdoses, infectious diseases such as HIV and hepatitis, as well as wounds and infectious diseases at the site of injection and issues like that. In terms of reduced access to STI services, we see reduced detection and treatment, and that means further transmission, as well as adverse outcomes such as congenital syphilis, infertility from untreated STIs, or HIV, which someone who has another STI is at greater risk for contracting HIV. So these are all, some of the negative outcomes we see when people can't get access to harm reduction or STI services. Next slide, please. So I wanted to hone in on congenital syphilis for just a moment. This is a condition that refers to parent-to-child transmission of syphilis during pregnancy, and it can result in miscarriage, stillbirth, prematurity, or other pregnancy complications. And with the rise in syphilis that we've seen, as Kate described, we've also seen a really sharp increase in congenital syphilis cases. And there's also, specifically, as Kate was discussing, some of the connection we see between syphilis cases and injection drug use is especially pronounced for women. And so, of course, we are seeing, a real strong connection here between injection drug use and risk for congenital syphilis. So this chart, which was developed by CDC to accompany a recent surveillance report, this demonstrates some missed opportunities for congenital syphilis prevention. And so most cases of congenital syphilis that we're seeing in the US are associated with no timely prenatal care and syphilis testing or inadequate treatment of syphilis during pregnancy. So what we're seeing is failure sort of across the system. Clearly, our current systems aren't meeting the needs of pregnant people. And so engaging various stakeholders, including harm reduction organizations, will be critical to addressing congenital syphilis, especially because of some of those barriers to accessing services that we've discussed. So there's a lot of reasons that pregnant people who use drugs might not want to access services, fear of criminalization, fear of losing custody. So it's important that we're really, considering various stakeholders, including those that have already built trust with people who use drugs, when we're trying to address these gaps in, or these missed opportunities in preventing congenital syphilis. Next slide, please. So now I'm going to talk just a little bit about some of the systems and partners that have the potential to address this syndemic, as well as some key strategies to consider. Next slide. So on the screen, you'll see some key partners that are involved in addressing syphilis and drug user health. And the Venn diagram here really represents what organizations are traditionally tasked with doing, or what might fall into sort of their official mission statement. Historically, syphilis has been addressed by public health and healthcare partners, in particular infectious disease departments at health departments, and sexual and reproductive health clinics as well. Drug user health has primarily been addressed by harm reduction organizations, as well as to some extent addiction, recovery, or behavioral health organizations, departments, or providers. And then in the middle, we see tribal health organizations, healthcare systems and providers, and Medicaid or other insurance companies are presumably tasked with addressing both of these. Now, in reality, we know that there's many deviations from these roles. Harm reduction for organizations, for example, I've put them on the right side with drug user health, but they have historically sought to advance the health and well-being of people who use drugs historically or holistically. And so, they could really, fall in the center of this Venn diagram as well. Additionally, realistically, we often see that healthcare systems or organizations aren't actually addressing drug user health or at times even syphilis and other STIs. And certainly we know that, there's a history of addiction, recovery, and behavioral health services, not necessarily including harm reduction. So with many caveats, I just want to use this slide to highlight some of the key partners to consider when addressing this endemic of syphilis and drug user health. Next slide, please. So recognizing the role that social and contextual factors play in recognizing some of the populations that are inequitably impacted by substance use related harms and syphilis, there are a number of other organizations and systems that we should consider reaching out to. So I've put just a few on the screen outside of the Venn diagram here, considering housing programs or economic development programs, considering racial justice organizations or refugee, immigrant, migrant service providers. So these could be activist organizations or they could be healthcare organizations that specialize in working with specific populations. Certainly, different organizations have different approaches to working with the criminal justice system, but the criminal justice system does certainly interact with a lot of people who could benefit from these services. And then peers, people with lived experience are critical to engaging in this work so that we can make sure that our services and strategies really are meeting their needs and the barriers that they face in getting access to services. Next slide. So key strategies to addressing this endemic include addressing these public health challenges collaboratively. So, a big first step is seeing how you can integrate services. And we'll talk about that a bit more in the next couple of slides. Another strategy in this, is very similar to what Kate said about putting the people first, is prioritizing populations that are inequitably impacted by this endemic when designing our public health services and interventions. So this is really important because inequities don't solve themselves. If we try to take a universal strategy that's designed for the general public, we're going to see the same or worsening inequities. And also many of the strategies that we might use to reach people that are disconnected from healthcare or public health, those strategies can benefit everyone. So making services more accessible, making sure providers are talking about these issues in a non-judgmental way. These can really benefit everyone, but they ensure that we're meeting the people who are most inequitably impacted. And then finally, addressing the social determinants of health, such as poverty, housing, employment, as well as those shared barriers to accessing health services, is really critical to both address those inequities, but also ensure sustained improvements in access to services. Next slide, please. So we're going to hone in for just a couple slides on the integration of services. And so what the nature of this syndemic tells us is that STI service providers interact with people who would benefit from harm reduction services and vice versa. And so linking or integrating services provides this opportunity to provide more holistic care. So not just meeting, one of their health needs, but meeting their more holistic health needs. We also know, as we've discussed, some of the connections between sexual and mental and behavioral health. So addressing one of these health challenges can directly benefit the other health challenges. And then finally, we are trying to reach populations that have fewer connections with the public health and healthcare systems. And so integration of services is also just a really great opportunity. It's a way to, essentially take advantage of these more limited touch points with public health and health. Slide, please. So integration models are as diverse as the organizations that provide syphilis and harm reduction services. But some common strategies are a one-stop shop model, and this is where STI and harm reduction services are co-located. Mobile or satellite services, so this often involves bringing one set of services to another. And then referrals and more intensive case management or patient navigation. Next slide. And on the screen, I've highlighted some different examples of these services. I do just want to hone in specifically on mobile or satellite services. And so this often involves partnerships between STI and harm reduction service providers, where one provider essentially brings their service to another. So an STI service provider might send one of their clinicians to work on site at a harm reduction facility. Or a harm reduction provider might park their mobile van next to the STI clinics. Or they might, host supplies for one another. So there's a lot of different strategies that this can look like. And next slide, please. Choosing the integration model that's best for your organization, it really depends on your organization, your partnerships, the resources available in your community, and then of course the needs of your community. But one thing that I really want to flag in closing, this part of the presentation is that a key principle of harm reduction is meeting people where they are. And so while it's really important to encourage people to come to you and make sure that your organization or clinic meets their needs, when possible, it's helpful to consider who is already reaching these populations, who do they trust, and how can we bring the services to them. And then I believe that might be my last slide, but you can go to the next. Yes, just a quick shout out to some NACCHO colleagues who I stole a few slides from. And then I wanted to include the references, so when we send the slides out, people can access those if they're useful.
Thank you so much, Kat and Kate. That was a really great kind of foundational overview and grounding for moving into the breakouts to kind of dig a little deeper. We did have one question that came up that I want to pose to both of you. Can someone address the impact of shared IV needles and the transmission of syphilis, not just the sexual transmission of it?
Kat, do you want to start in on that, or should I go ahead?
I'm not sure I'm familiar with if there's anything beyond the sexual and contextual factors that we've chatted about.
Yeah.
So I'll turn to you, Kate.
Yeah, I mean, I don't know. I don't have all the answers, but I can try to take a stab at this question. We know that from research that typically syphilis is it's not typically transferred through needles. It's not a blood-borne infection in that way. It is the primary way that it's transferred by is through sex. However, when we look at the overlapping networks between drug use and risky sex and syphilis, we see that they're very much co-occurring together. And so the network, and often your partner who you share drugs with is often the partner that you have sex with as well a lot of times. And so there's a power dynamic in this as well that shouldn't be forgotten. So in terms of does syphilis spread by dirty needles, as you say, I would say that is not the primary way that syphilis spreads. It is more about sexual and contextual factors. Over.
Thank you. So let's keep throwing any questions in the chat. Because of time, we are going to move forward into the breakout rooms, but we'll try to come back to any questions afterwards. And then we can also do some more research and follow up on any question that we don't get to.
Kristen, can I just amend one of the things I said?
Yeah.
So what I meant syphilis is a bloodborne disease, full stop. However, we don't have a lot of research that shows that it is transferred via needles.
Thank you for that clarification. Okay, transitioning into breakout rooms. So as I mentioned at the beginning, we wanted to leave some space for a bit of a deeper dive into syphilis basics for folks who primarily work in harm reduction, drug user health, and then vice versa. So a deeper dive into harm reduction for those folks who mainly work in STI prevention and treatment, or really any field that is not directly working with people who use drugs. So you should see in a moment an option come up on the screen to select the breakout room that fits best with your needs. So folks working in STI prevention and treatment, you can select to go to the harm reduction basics breakout room, and people working in harm reduction, you can select to go to the syphilis basics breakout room. We'll be in breakout rooms for about 25 to 30 minutes, and then we'll all come back for 5 or 10 minutes to close as a whole group.
17. Or thank you. Pop it in the chat if that's not working for you. I appreciate that. So, I love Menti too if I could really get it to work, because they get enjoyment out of it. Pleasure. Yes, like that's a huge reason that people use drugs, at least in the beginning, right? Maybe not later if you become dependent or develop substance use disorder, but pleasure a lot of times. Peer pressure, absolutely, to deal with challenges, yes. Self-medication for mental health issues like anxiety or depression, escaping reality. I'm seeing a few people talking about trauma. Fun, thank you, I like that one. Coping, boredom, yes. Pain management, medical issues, all of this. I think, social gatherings, anxiety, curiosity is a huge one. Thank you. Love it. These are all really, really great responses. The sort of to stay awake. Thank you for that one. The point really being that there are myriad reasons for taking drugs, right? From curiosity to trauma to fun to one that I don't think I saw in the chat that is relevant to this conversation is sex, right? So more pleasurable sex, longer sex, less social anxiety, maybe. These are all things that folks, seek help with, and sometimes that help is substances, right? I apologize for this. Next time, Mentimeter will maybe work better for us. So let's get into this conversation. Really high level, sort of, what is harm reduction, right? So harm reduction is a set of strategies and ideas. No one thing is harm reduction, particularly as the drug supply continues to change. And so harm reduction changes with it. And harm reduction is really aimed at reducing negative consequences associated with drug use. And that word is really important, right? Because, harm reduction sees that many of the harms that come from drug use is not coming from the drug in and of itself per se, but is a result of the conditions in which we're using drugs, right? And then it's also important to remember that harm reduction is a social movement. It is built on respect for people who use drugs, respect for the human rights of people who use drugs. And so advocacy, whether it's individual patient advocacy or policy advocacy ends up being really important in this work. There are 8 general principles that underlie the work of harm reduction. And without these principles, the work doesn't work. Without these principles, the work is not harm reduction, right? So we follow this sort of guidance from National Harm Reduction Coalition from the 90s First, we accept that drug use happens, for better or worse, and we choose to minimize harmful effects rather than ignore or condemn them, right? A drug-free world, in our estimation, is never going to happen and has never existed, so it probably won't. We understand drug use as a really complex phenomenon that has a lot of nuance, that encompasses a sort of spectrum of behavior, including abstinence. Not using a drug is a way to have a relationship, right? And acknowledges that different ways of using drugs can be safer or less safe, right? We establish quality of life as the key metric for success, right? Whether that includes abstinence or not, as long as folks are, meeting some of their goals and they perceive their quality of life to be good, then we're excited about that. Sure. And harm reduction is non-judgmental and non-coercive always. And if anything starts to look coercive, we don't call that harm reduction. And it doesn't mean that we aren't judgmental folks or that judgments fly out the window, but we work really, really hard on that poker face and then bring our issues back to our staff or our supervisors or what have you. Because, and we'll talk about this, but because harm reduction was created by people who use drugs for people who use drugs, it is imperative that drug users have a meaningful voice in the creation of programs. Folks are themselves the only people who can make change. So we want to empower folks with the knowledge, the information, the strategies to stay safer. And of course, we recognize that all of the isms and all of the social conditions really impact whether the degree to which you're vulnerable for some of these harms and your capacity for addressing them when they arise. And lastly, we don't minimize or ignore any of the real and tragic danger associated with drug use and believe a lot of policy needs to change to alleviate that. And then a quick note, I always want to, we stand on the shoulders of giants, right? And I always want to acknowledge that syringe services programs in particular were invented, created, forged by harm reductionists, by people who use drugs specifically at risk of arrest and incarceration for doing so. Still to this day, that may be the case where you are, I don't know. But the inclusion of folks who use drugs is essential because this is the work of people who use drugs, right? I think that's it from me. Kirsten, do you want to take over and I'll advance your slides?
Sure. Thank you so much, Christine. I'm gonna try to pin myself. I don't know how to pin more than one person. So anyway, if you figure that out.
I got you. I pinned you.
Thank you so much. Syringe services programs are one of the interventions that kind of fall under the umbrella of harm reduction. And they provide services to people in active use, both injection and non-injection routes of administration, using self-directed goals without the expectation that they stop using drugs. And so that's somewhat unique because oftentimes people face the barrier in terms of accessing services, whether that's housing or employment or other services, and abstinence is a requirement or an expectation before someone is able to access that resource or start sort of making those changes in their lives. And as harm reductionists, we recognize that when abstinence isn't the goal or isn't, on the table at that moment or maybe ever, there's actually a lot of support that we can provide to people and a lot that people might be motivated to change in their lives regardless. Syringe services programs provide supplies and resources to folks so that they can live as safely as possible and prioritize non-judgmental, non-stigmatizing, non-coercive, strengths-based, and mutually respectful engagement. So Often we will call these SSPs. They're also sometimes called syringe access programs or needle exchange programs. They all sort of mean the same thing, but the language has shifted as it's been sort of public healthified. Syringe service programs also sort of has the connotation that it's more than just providing sterile syringes and returning used syringes. There's often a lot of other programming that goes into these services. Next slide, please. Oh, that's a great question. Other sectors of harm reduction aside from drug use. So I'll just quickly mention that harm reduction as a movement has, I think, a specific history born out of, the work of people who use drugs and taking care of each other and their communities, and is related to the criminalization of drug use. But harm reduction as a concept can be applied to lots of other areas of life. So we all take risks and engage in risky behaviors. And so, but there are things that we do to try and reduce those risks and harms. I think sex education, condom distribution, STI prevention, recognizing that people are still having sex, but there are ways to be protected from certain adverse outcomes. I'm seeing some answers in the chat, but I think we don't want to disentangle harm reduction right now in terms of this discussion from the specific history of criminalization, often with its roots in racism, of people who use drugs. So unique strengths of SSPs. So one of the primary strengths is that SSPs focus on trust and relationship building. And often kind of building a relationship is the primary goal, rather than necessarily identifying someone's need real quick and trying to solve a problem for someone. The focus is not on a kind of hierarchical relationship, like I'm the service provider and you're the client, and I'm gonna sort of tell you what you need or fix your problem for you. It's more of a kind of level playing field. Let's just create a safe space for folks to kind of be themselves and go from there. It's a point of engagement and can be a way of accessing other services. So people may come for syringes, other injection equipment, and then get to talking about maybe, methadone or other types of substance use treatment, or getting an HIV test, or finding out how to get health insurance. SSPs also, because of those relationships with people who use drugs, develop a knowledge of the changing drug use patterns and drug supply trends, and so are often in the best position to kind of understand what the next wave of potential drug use issues might look like, and be able to sort of respond quickly and be adaptable, leading into the next strength, ability to be nimble and adaptable in response to evolving needs. So many SSPs were aware of the changing drug supply when folks transitioned from prescription painkillers, for example, to heroin, and heroin started to become more available. And then we saw fentanyl, illicit fentanyl, adulterating the drug supply. And finally, frontline overdose prevention and response. So super important. SSPs do a ton of things, but one of the really crucial things that they do is get information about overdose and how to respond to overdoses and naloxone out into the community of people who use drugs. So let me keep going here. Thanks, Christine. Next slide. Okay, who do SSPs serve? People at high risk of overdose. And that includes, in particular, people who have just been released from detox and might have a lower tolerance at that point when they potentially return to use, and people who were recently released from incarceration. people living with and vulnerable to HIV, viral hepatitis, and other infections, people who inject drugs, and also people who don't inject drugs. So some programs provide information and supplies around safer snorting or safer smoking, people who are houseless or unstably housed and food insecure, and people who engage in sex work, particularly street-based survival sex work. Next slide, please. So there are many different models of SSPs and of service delivery. A fixed site could be a brick and mortar location, street-based outreach via a van or a kind of walking backpack model, secondary distribution or peer-delivered syringe exchange, by which we mean someone who is a person who uses drugs or has close ties to that community in their local area and distributes supplies on behalf of the program because of the access to networks of folks that that trusted person has. You can use pharmacies that either sell or provide for free syringes to folks who are injecting drugs, delivery methods, and mail-based programs. So many programs combine multiple models of service delivery in order to maximize their reach. And for example, we saw a lot of programs that might have been fixed site or brick and mortar switch to mobile or delivery-based services during the pandemic because that was safer in terms of trying to avoid close interaction with folks. And then some of those programs stuck with that model, even as the risks of the pandemic have declined, just because it was a much more effective way of reaching people going out to where they are. Next slide, please. Okay, so a range of different services. I talked a little bit about supply distribution, safer drug use supplies, overdose prevention, safer sex, hygiene, wound care kits. Often SSPs are just helping to meet folks' basic needs. And a lot of supplies aren't necessarily just about drug use. So hygiene, socks, tents, food. And then besides supply distribution, programs also provide access to care. That might be via formal referral and navigation or case management, might be a bit more informal, just kind of warm handoffs, or it could look like on-site co-location or integration of services. Next slide, please. SSPs provide education, support groups. They may provide case management, or access to additional services such as a drop-in space where folks can hang out, nap, meet other folks, store medication, take a shower, have some food, access computers. And SSPs also play the important role often of holding space for community grief, for memorials and vigils, especially for folks lost to overdose who might not have the opportunity to participate in some of those formal grief rituals. Next slide, please. All right, and I think this is my final slide. So opportunities for potential collaboration with SSPs. This could look like information sharing between harm reduction staff and STI staff around trends related to STIs or drug use patterns. Just a note there to consider anonymity and confidentiality protections. So SSPs often operate anonymously and are, very kind of fiercely protect the anonymity of their participants because of the legal risks related to drug use and paraphernalia. Staff training and capacity building is another way to collaborate locally. So cross-training STI and harm reduction staff, sort of similar to this webinar today, but more in-depth to ensure that kind of folks have the skills and knowledge in both of these areas. forming referral partnerships. Again, SSPs, place a priority on trust and relationship building. And so they may be the best messengers for services around STI testing or treatment, rather than, someone who's, someone that they aren't familiar with, who's from the health department. And then finally, integrated services. So STI testing and treatment on site at SSPs or vice versa, which I know Kat mentioned a little bit. So I'm going to pause there. I'd love to hear from you all. What other opportunities for collaboration and partnership come to mind? And any other questions that you have for us in the next 5 or so minutes.
While you're thinking of your questions or other collaborations, I just want to quick note, there's some contact information here. There are some resources here. Folks will get the slide decks, but I am going to stop sharing so I can see your faces. Any questions out there? Anything that we didn't cover that you'd like us to speak to? Totally. Working with CBOs or volunteer groups that advocate for the unhoused. SSPs are sort of de facto homelessness services providers, right? So absolutely. Yeah, and thanks. There's like so much stigma around drug use that for a very long time, this is still the case, although it's been changing, that folks had nowhere to grieve because they felt too much shame to disclose that their loved one died of an overdose, right? And so what do you do with that grief and that pain? And so folks try and hold space for that. Ooh, that's a good question. Did you see that one, Kirsten? In jurisdictions where SSPs are barred. Well, the first thing I'll say is that just because SSPs are not legal in your jurisdiction doesn't mean they don't exist. They are still partnerable, and it may be harder to find them, right? So good. Oh, that's awesome. Wonderful, Jinda. But I don't know. Kirsten, do you have any examples off the top of your head from working with health departments?
Yeah, I mean, I think in places where SSPs are not legal and maybe not many of them exist, there's also a lot of work happening around overdose prevention. So most states have laws around naloxone distribution, and there are a number of groups probably still who are doing overdose education and response, passing out naloxone, which also kind of puts them on the front lines there in being in touch with people who use drugs. Yeah, I don't know. It's something to explore in terms of your unique local situation.
Yeah, I would start building relationships and just sort of asking around, like who works with the folks that you're working with and that sort of thing. I personally don't know the intricacies of STI testing such that I know what's reportable by law and what isn't. So I think that would impact whether STI testing could be anonymous at an SSP. But certainly, request the least amount of data possible for any services and kind of leave it at that.
And I think many SSPs have a sort of an anonymous side. And then if they do more intensive case management, then they have a sort of case management side. So it's about like that communication, like these services are anonymous, and whatever you do in terms of receiving injection equipment or other safer drug use equipment, that's separate from the case management activities that we might do together. And that might include STI testing, for which we would collect, your name and some other personally identifiable information. And I think that that works best when those trusting relationships have been formed. And I know an SSP in Baltimore, for example, that has a nurse who's technically employed by the health department, but is embedded within the SSP. And so that nurse practitioner does STI testing. They'll go out in the field and she'll do self swabs for folks, and then they'll provide treatment. There's another question here about SSP and pregnancy care collaborations. If anyone has good examples, talking about expanded prenatal screening for syphilis. I'll let Christine answer, but I'll make a plug for the next session in this webinar series at the end of April. That one's focusing on congenital syphilis and working with pregnant people who use drugs. So
yeah, totally. And I think I'd like to take some time to respond to this in writing, as well as the next question about treatment engagement, because they're great questions. But you know, I think it depends on your jurisdiction, right? Like there are some providers that will, you know, graciously and helpfully refer pregnant folks to exchange. That is rare, right? That's something that's going to be proactively offered. I know that there are some doula programs, like speaking of Baltimore, that have doulas specifically that work with women or other pregnant folks who are using substances or who are incarcerated. And SSPs, I think, like, are, in my experience, are down for all of these partnerships. They just don't have the money to initiate them, right? So any extra services to participants are always desired and welcome, but it's a matter of resources, right? So if there's any way that you think an SSP might fit into pregnancy care, and I think there are a few ways that that could be the case, then I would reach out to them for sure. Well, thank you. And we'll try and get to this last one in writing, I guess. Yes. Okay.
Yeah, that sounds good. Thank you, everyone. We really appreciate you being here. We'll go gather all together in the main session now. But yeah, keep sending questions through chat. I've saved that for this session. Thank you. I'm going to save it again now that people are writing things.
Great. Thanks, y'all, so much. Send us questions anytime. Have a wonderful evening, afternoon, wherever you are.
All right, I think we're going to get going. Kate, you want to start us off?
Yep, sure thing. Hi, everyone. Thanks so much for joining our breakout. We're going to go over some syphilis basics, specifically for programs serving people who use drugs. I'll intro myself. I'll let Rebecca intro, and then we'll move into it. So my name's Kate. My pronouns are she, her. I work at the National Coalition of STD Directors. My background is nursing. I've worked in sexual health throughout my nursing career. And Rebecca, you can go ahead.
Hey y'all, Rebecca Horowitz. I'm the Director of STI Programs at NACHO, the National Association of County and City Health Officials. So we're the membership organization for local health departments, of which there are about 3,000 across the US. Pronouns she, her. Prior to working at NACHO, I also worked at NCSD. So yay, national organizations working on STIs.
Awesome. All right, so we can go ahead and get started with the first slide. So some basic facts about syphilis. It's a curable sexually transmitted infection transmitted through direct sexual contact, oral, anal, vaginal. The syphilitic sore is the direct contact where the bacteria enters the body, and that's called the chancre. Syphilis is known as the great imitator, so symptoms can have a similar presentation to a large variety of other diseases, which often causes misdiagnoses and can delay treatment. caused by a bacteria called Treponema pallidum or T. pallidum. That little squiggly you see is the bacterium, the spirochete. Can cause serious problems, serious health problems without treatment, and the infection develops in stages. So we're just going to go through and kind of break down each stage. And we can go to the next slide. So primary syphilis is the initial stage, and you can see in that photo that is an example of a chancre or the sore. It presents with single or multiple sores about 2 to 6 weeks after exposure at the site of infection. Chancres are generally, but not always, firm, round, and painless. There are some cases where the ulcers can cause discomfort. But if it's painless, for that reason, it can be difficult to detect. So if it's inside the mouth, the anus, the vagina, sometimes it goes unnoticed and therefore undiagnosed and untreated. It lasts for about 2 to 6 weeks, and it will heal and go away if it's not treated. And in that case, it does progress to secondary syphilis. And next slide, please. So secondary syphilis, it can present with skin rashes on one or more areas of the body. Oftentimes it starts on the trunk, so the chest or the back, and spreads to the hands or the feet. Rashes can be rough, red, or reddish brown, don't generally cause itching, and they can be faint or hard to notice. So as you can imagine, in this stage, it can be a little difficult to detect or diagnose as well. There can be swelling of lymph nodes, so that can happen in the groin. It can sometimes be tender. Sores in the mouth, vagina, or anus. Condyloma lata is another symptom that can occur, and those are large, raised, grayish white lesions. Those can develop in warm, moist areas of the body, like the mouth, the underarm, or the groin region. Other symptoms, fever, muscle aches, generalized headache, fatigue, and these signs and symptoms may disappear within a few weeks or can repeatedly come and go for as long as a year. So without appropriate treatment, the infection can move on to the latent and possibly tertiary stages of syphilis. And next slide, please. So in latent syphilis, there are generally no symptoms. This stage is known as the hidden stage of syphilis. Without treatment, someone can have syphilis for years. And to make things even more complicated, there are 3 different categories of latent syphilis as well, as you can see on the screen. So in early latent syphilis, this is where the infection occurred within the time frame of the past 12 months. Late latent is the infection occurred more than 12 months ago. And latent syphilis of unknown duration is where there's not enough evidence to confirm if the initial infection was within the previous 12 months. So this stage really emphasizes the importance of a thorough sexual health history when testing or treating for syphilis. And treatment is different for latent syphilis, and we'll touch on that later in the presentation as well. And next slide, please. Tertiary syphilis is rare and can be fatal. It can occur within 10 to 30 years of having syphilis, and it affects different organ systems, and symptoms vary based on which organ system is affected. Next slide, please. So we'll talk a little bit about neurosyphilis, ocular syphilis, and autosyphilis. Without treatment, as I said, syphilis can spread to the brain and nervous system, the eyes, or the ears, and this can happen during any stage of untreated syphilis. Symptoms can be broken down based on which system they're affecting. With neurosyphilis, that is the nervous system that's affected. You could see headache, muscle weakness, numbness, or any changes to mental status. Ocular system is the affectation of the visual system. So you'll see eye pain or redness, any floating spots in field of vision, sensitivity to light, any changes in vision really. And finally, autosyphilis affects the auditory or vestibular system. So that could be hearing loss, ringing, or any form of tinnitus, balance difficulties, dizziness, or vertigo. And next slide, please. And congenital syphilis. So congenital syphilis occurs when a pregnant person passes the infection to the baby during pregnancy. The placenta does not provide any protection, and this can affect the fetus while in your utero. So the effect on the baby depends on how long the person has had syphilis or when they receive treatment. So a lot of different things can occur for the fetus or the baby. Miscarriage or stillbirth can occur. The baby can be premature, have a low birth weight, and babies born with congenital syphilis do not always immediately present with signs or symptoms. If they're not treated, they can later die from infection. They could be developmentally delayed or have seizures. So for that reason, it's really important to emphasize that all pregnant people should be tested for syphilis at some point during their pregnancy. As we know, prenatal care is not always accessible or possible for some folks, but just for a pregnant person to get tested as soon as they can. And then I'll pass the remainder of the slides on over to Rebecca.
Thank you. Of course, I just hid my own notes behind the screen when I went to unmute myself because, you know, it can never be easy. So we're going to just talk a bit about syphilis testing. So testing happens through a blood draw, as we sort of alluded to in the conversation before. Syphilis is a bloodborne disease. Lots of folks believe that they are getting tested for syphilis on a regular basis when they're getting a urine test for STIs. So when they provide a urine sample, but this one is different and does require a blood draw. The testing is a little bit tricky because it actually requires two tests, a non-treponemal test or RPR, and a treponemal test, also known as TPPA. You'll hear lots of acronyms. I'm not going to read them all. There are at least 18 treponemal specific tests that are cleared for use in the United States. Use of only one type of test, so either non-treponemal or treponemal, is insufficient for diagnosis, and using just one can result in a false negative among persons tested during primary syphilis, or a false positive among people who who never had syphilis or were previously treated for syphilis. Once someone has had syphilis, their treponemal test will always be positive, which explains why there may be a false positive. So indication that a person currently has syphilis when in fact what's being detected is a previous case of syphilis. And a non-treponemal test, which looks at your titer levels, will tell if someone has been reinfected and needs treatment again. So if you have a treponemal test that comes back positive, if a person thinks that they've never had syphilis before, you would want to confirm that in fact they have a new case of syphilis, regardless of whether or not they believe they've been treated previously. Next slide. Okay. Hold on. Let me just make it a little bit bigger for myself. So the treatment for syphilis is a single injection of a long-acting penicillin called benzathine penicillin G, which can cure the early stages of syphilis. 3 doses of the medication at weekly intervals is needed for latent syphilis, and many health departments will recommend the 3 doses if it is syphilis of an unknown duration, just to make sure that they're fully treating. State and local health departments are almost always going to have this medication in stock, but because of access outside of the public health system, it can be pretty expensive to buy the drug. So if you can't get it, if you work closely with your health department partners, they can usually come out and provide support to get people treated. And if you provide clinical services and you're not utilizing the 340B drug pricing program, which allows you to access penicillin for a much, much, much cheaper price, you should definitely reach out to my organization, NACHO, or Kate's organization, NCSD, for technical assistance to talk about how you might be able to access the 340B drug pricing program for that more affordable access to penicillin. It's like $1 through the 340B program and $1,000 for not 340B. Generally, if you're helping someone go to get syphilis treatment, it's good to warn them that the medication is cold and thick, and it's divided up into 2 syringes. So it's like generally not the most pleasant thing to be treated for. But because it's not that pleasant, people generally remember if they've been treated for syphilis. So it's one of the ways that you can figure out whether or not somebody has an active case of syphilis or not. Is you can ask them if they've ever been treated for syphilis, and they'll usually remember, because it's, not the most pleasant shot to get in the world. Next slide. So there are a lot of myths about syphilis, and we're just going to debunk a few of them. You cannot get syphilis through casual contact with objects such as toilet seats, doorknobs, swimming pools, hot tubs, bathtubs, sharing clothing, or eating utensils. These are a lot of the same myths that were, circulating around HIV and AIDS for a long time in our country and still are. So just wanted to make that point. These are not ways that you can get syphilis. Next slide. So as you can see on this slide, CDC syphilis screenings have special recommendations for screening for a lot of particular populations, but the recommendations do not call out any special considerations for individuals who use drugs. But in my opinion, and I think in the opinion of most of the organizations that are hosting this call, it's a mistake that they don't call them out specifically, because there are particular considerations that should be kept in mind. We know that syphilis is rapidly increasing in individuals who use drugs, and therefore testing and treatment for these individuals when they're receiving medical care should be prioritized. But at the same time, to prevent and or treat syphilis, we have to provide opportunities for individuals who use drugs and do not receive any medical care, or do not receive medical care on a regular basis, to be tested and treated for syphilis. So this can take place in many different settings, but really any setting where an individual is receiving harm reduction services is an opportunity to be interacting with them about syphilis. And it's especially easy to add this syphilis test in if you're already offering HIV testing, because there are dual rapid tests. So just like the finger prick test, there are dual tests for HIV and syphilis. Next slide. So special considerations are people who use drugs with regard to syphilis. Some of these were touched on by Kat and Kate, but just to reiterate a few. Increased risk for syphilis and other STDs is because of behaviors, because of stigma, mistrust of the healthcare system, and then also social determinants of health. So things like unstable housing. The intersecting epidemics of sexually transmitted infections and substance abuse or use make it harder to identify and treat people with syphilis, because drug use makes people less likely to be going to a doctor and or reporting their sexual partners. It also makes pregnant people more reluctant to seek prenatal care and to get syphilis testing and treatment because of concerns around reporting and the involvement of the criminal justice system. So drug use, particularly the use of methamphetamines and injection drugs, is associated with sexual behaviors that increase the risk for acquiring syphilis and other STIs, including having multiple sex partners or concurrent sex partners, inconsistent condom use, and exchange of drugs for sex for drugs or money. In addition, among people who use drugs, stigma and mistrust of the healthcare system, along with other social determinants of health, unstable housing, poverty, incarceration, lack of health insurance, might contribute to a decreased healthcare utilization and a reluctance or inability to identify and locate sex partners, resulting in delays in diagnosis and treatment. So all of these complications are likely to contribute to an increased syphilis incidence in these communities and pose significant challenges to syphilis prevention and control efforts. Next slide. So what can you do? Most SSPs and harm reduction service providers already do HIV testing, and many often do HIV linkage to care. But if you don't, it's pretty easy to add these services. And if you do, it's pretty easy to add additional STI services, and especially syphilis, because you are already doing the blood draw or the prick to get blood to do HIV testing. So some things we recommend, in particular, you could provide a safe space for clients to ask questions about syphilis, provide condoms, encourage, if not provide, routine screenings for STIs, especially syphilis. Recognize the symptoms of syphilis. We know that y'all are probably not doing genital exams, but seeing the chancres that Kate showed earlier in the slideshow, what it looks like on the mouth, what the rash looks like on the hands. You don't want to be going up to every single person that you interact with that see a rash on their hands and asking if they have syphilis. But certainly thinking about if you're starting to see a pattern of those symptoms being shown more and more often, have a pop-up day where you have the health department come in and do syphilis testing, if that's the fastest thing you can do and you're not ready to be adding greater integration of STI services. Then obviously offering testing is ideal, but if not that, an active referral system to get syphilis testing, encouraging and easing access to ongoing prenatal care for those folks that are pregnant, and then providing disease intervention services or linking with the local health department to work with you to conduct partner services or disease intervention services. So that, if an individual is having sex with someone that has syphilis, that individual is likely to also have syphilis. So making sure that not just the folks that are coming into your center are having these conversations, but also that they're having conversations with their partners. And if not, that the health department is involved in having those conversations and making sure folks are getting tested and treated as well. Next slide. So we want to just open up the floor and ask people who would like to unmute themselves and just let us know what you're doing at your facility around syphilis prevention or treatment and care in your organization. Or if you're not doing anything, what you could see yourself doing if you had the resources to do it. Does anyone want to share?
I could share.
Go ahead.
Hi, I can share. My name is Kate. I work at a methadone clinic, addiction treatment center with co-located primary care. So we do testing through our methadone clinic and our addiction treatment center, other programs, and do our treatment through our medical practice. And we actually started out with, when we started seeing syphilis popping off among our patients, we started off by contacting our local health department, as Rebecca had suggested doing, and they were able to come over, and then they were able to lend us, leave some Bicillin with us, so we were able to administer. And now we've gotten to a place where once we could financially justify it, because we have so many patients, now we're purchasing our own Bicillin, keeping it in stock so that we can, treat people as quickly as possible, which has been great, but we don't get 340B pricing on it, and hopefully we will soon.
Yeah, Kate, if you're not talking to the health department already about the ability to do 340B, you can register for 340B access via your relationship with the health department. So if you're not talking to them and you want to talk to them about that and bring in someone else to help with that conversation, let me know.
Thank you.
Yeah. Before we go to anybody else, there was a question in the chat. Are there rapid tests that can detect a current syphilis infection? So the rapid tests will detect syphilis, but they will not tell you whether or not it is a current case of syphilis or a previous case of syphilis. You'll have to follow up with those conversations, asking folks, have you ever had syphilis before? Do you remember getting a painful shot in your butt? So you could still do presumptive treatment, and you can, so yeah, we definitely recommend the use of rapid testing. There's not a lot of evidence of, problems with it, besides the fact that you would have to do a follow-up test to determine, is this a historic case or an active current case? Yeah, Sonia put in some info in here about how the rapid test program that they were doing with a syringe exchange in Seattle, and that is super, super common. Folks going out who have mobile units, either having the health department go to a harm reduction facility or going out on the same mobile unit to provide syringes and different harm reduction materials, as well as having that rapid syphilis test. And as I said, there is the rapid syphilis and HIV combined test, so you don't have to take two pricks. You can just take the one prick and do the testing for both. Janelle Clark asked the question, any suggestions on STI standing orders for a new STI treatment clinic? Janelle, I am going to recommend that you email myself and Kate. And I think our info is at the end of this slideshow. If not, we can go back to the beginning so folks can have it. Depending on where you are, we definitely would have suggestions, but it's particular to your location. So just send us an email and we can help you with more of that. Additional folks who want to share their current experience with integrated, as a harm reduction entity, doing syphilis prevention, treatment, or care.
I've got one if you want.
Yeah.
So my name's Sam. I use they and she pronouns. I'm with the Pima County Health Department and I work in the HIV STD prevention team. So part of it is that we're just kind of already integrated. We have a needle exchange program as well as an STD prevention. And Mondays and Fridays, they are in the same building. So it's one-stop shop. So they can, I'm gonna say Fridays are a little easier just due to logistic things that are out of my control at least. But basically like they can come in, get their supplies, get anything they need regarding that, and then they can literally go the next door over and get tested for HIV, syphilis, gonorrhea, and chlamydia.
That's awesome. Yeah, co-location is our best friend, and everything else is our good friend. So it looks like our time is up for the this breakout room. I'm going to ask if we can go back to the first slide real quick so that folks can see our email addresses. Oh, no, we didn't put them on there anyway. That would have been too smart of us. But we'll put them in the main chat, or, you can follow up on any of these conversations. Just back to the email that you got when you registered and say you would like to talk to us about STI standing orders for STI treatment in a new clinic, or any other questions that you have. So I'm going to close the breakout room, and I'll put my email in the chat in the main room, just in case folks need it.
Hello. I think folks are still making their way into the main session room. I hope that you were able to get some good info and maybe have a little bit of discussion in your breakout rooms. And apologies for a bit of the delay and confusion in getting into breakout rooms. Thanks for your patience with us trying out these new aspects of technology. Okay, I'll just give another few seconds for everyone to return to the breakout room. I mean, the main room. Okay, great. So seeing many people who have returned to the main session, we have another quick poll here. So we asked everyone about their current knowledge when the session began, and I want to just quickly ask everyone, how would you describe your knowledge of the intersection of syphilis and drug user health now after participating in the session? Obviously, we're hoping that it has increased, that you're feeling, a bit more confident about your knowledge in this area. But if it hasn't, there are 4 more webinars in the series, so you're in luck. I'll just give about 15 more seconds to respond. Okay, great. Yeah, it looks to me like we've had some increase here. So 62% of folks would put themselves at a 4 out of 5 in terms of knowledge on syphilis and drug user health after the session. And then we have a group of folks at a 3 and a group of folks at a 5. Thank you for that. And here is a little preview of the next 4 sessions in this series. So I know that congenital syphilis has come up, and certainly in our breakout room, working with pregnant people who use drugs around STIs and syphilis has come up. So the next session at the end of April will be you can't screen patients who won't come in, taking a harm reduction and whole person approach to care for pregnant people who use drugs and promising practices. The next one at the end of May will be still Trepin, ongoing responses to syphilis in Indian country. Then at the end of June, we'll look at ways that state health departments are being innovative in terms of their structure, policy, funding at the intersection of syphilis and drug user health. And then finally, at the end of July, Solo Makes You Go Slow, local partnerships addressing syphilis among people who use drugs. So we'll look at on the ground, local health departments, other agencies partnering with SSPs and harm reduction programs, and what some of those models look like. For those of you who would like to learn more or would like to maybe get a bit more personalized assistance around either drug user health or STIs and syphilis, you can contact the National Harm Reduction Technical Assistance Center. This is coordinated by NASTAD, and we have a number of partners that are also TA providers, and we provide free targeted technical assistance to anyone who's providing harm reduction services or looking to start providing harm reduction services across the country. And the website is noted here. You'll also get the slides and links to register for the upcoming webinars in a follow-up after today's session. NCSD, the National Coalition of STD Directors, also offers TA to their members, and you can contact them at their website as shown here. And our partners, AIDS United, also do work around policy and advocacy, grant making, and capacity building. You can feel free to reach out to AIDS United's harm reduction team at the email listed here. And NACCHO is available for technical assistance and capacity building for local health departments across a wide range of health issues, but especially STIs, HIV, harm reduction, viral hepatitis, and the intersections of those topics. And you can contact them at the email listed here. Okay, one last poll before we close for those of you who are hanging in there with us here. So I think we put together a pretty comprehensive webinar series, but we do want to know what other topics or areas within this intersection would it be helpful for you to learn more about. So I am going to launch this final poll, and this is a short answer. What topics related to syphilis and drug user health would you like to learn more about? I'm hoping that it showed up and that folks are able to type in their short answer. Okay, great. And I don't think they'll show up on the screen, but we'll be able to look at them afterwards. So take your time. Feel free to list any additional topics that you'd like to learn more about, and that will help us as we plan out the rest of the webinars in the series. I know that we're just about at 4:30 Eastern, so we'll close for now, and I apologize for any of the questions that we didn't get to answer. We are saving the chat. We're saving the Q&A, and please feel free to reach out if you didn't get to ask a question that you'd like to have answered, and we'll do our best to follow up within the next week or two. Thank you, everyone. Take care. Have a great rest of your day.